I'm going to be talking to you about management of an impacted fetal head at caesarean section. So first of all, what is an impacted fetal head? Well, there's actually no consensus definition. It's a complication occurring at caesarean sections in advanced labour and is particularly thought to be associated with caesarean sections at full cervical dilatation. However, there's emerging evidence that it may actually be as common in caesarean sections performed prior to full cervical dilatation. The fetal head is very low and fixed in the mother's pelvis, and these are technically difficult births with high risk of complications. We performed a national survey of 345 obstetric trainees and labour ward leads, and most of them agreed that an impacted fetal head was difficulty and/or failure to disengage the head with standard manoeuvres. We've therefore developed a working definition of an impacted fetal head, similar to the shoulder dystocia definition, as caesarean birth requiring additional techniques and/or tocolysis to disimpact the fetal head after standard delivery manoeuvres have failed. So in terms of the complications of an impacted fetal head, they can complicate both the mother and baby. Maternal complications include damage to the uterus and urinary tract, uterine bleeding and postpartum hemorrhage, longer hospital stay, and hysterectomy. And babies can have skull fractures, intracranial bleeds, or nerve injury. And difficulties delivering an impacted fetal head can result in delays delivering a potentially compromised baby, and this can lead to hypoxic brain damage and, in rare cases, neonatal death. So how common is an impacted fetal head? Well, it was identified as a contributory factor in 9% of the NHS Resolution Early Notification Scheme cases, but there are actually few national or international data on incidence. We performed a retrospective cohort study of emergency caesarean sections in Bristol and found that impacted fetal head complicated 1 in 10 emergency caesarean sections and a third of caesareans at full cervical dilatation. And interestingly, over half of the cases of impacted fetal head were in caesarean sections prior to full cervical dilatation. We also conducted a national survey of practice and training, which was published in 2020, and that confirmed that an impacted fetal head is poorly defined and also showed that it was commonly encountered by UK obstetricians. Worryingly, some techniques are being employed that haven't been investigated and are not recommended. And it really highlighted the paucity of training for this emergency and that UK obstetric trainees are simply not adequately prepared to manage an impacted fetal head. Our retrospective cohort study also highlighted the risk factors for an impacted fetal head. Maternal and perinatal factors include primiparity and macrosomia, and intrapartum factors include features of an obstructed labour such as capitum moulding, oxytocin augmentation and epidural, and of course full cervical dilatation, failed assisted vaginal birth, and a mid or low cavity station. And interestingly, junior operators appear more likely to diagnose or at least document an impacted fetal head than consultants and senior obstetricians. So what can we do to prevent it? Well, one option might be to perform a vaginal push-up before incision, and that might be appropriate following a failed assisted vaginal birth. But at the moment, there's no evidence to support or oppose that approach. The fetal pillow is also becoming an increasingly popular device. It's essentially a soft silicone balloon inserted into the vagina to elevate the fetal head. And it can be used for caesarean sections with a deeply engaged head, at a fetal station at or below the ischial spines, or following a failed assisted vaginal birth. So what's the evidence? Well, 2 randomised control trials and some small case cohort studies have shown that the fetal pillow improves the ease of delivery, reduces operating time, and potentially reduces uterine tears. But actually, recent larger observational studies have shown no improvement in maternal or fetal outcomes. And it's not currently recommended by NICE due to issues with case selection and cost. At the moment, larger scale randomised control trials are required before widespread use. So, how should we go about delivering an impacted fetal head? Well, one way to think about it is to imagine trying to get a ball out of a flower pot. It's that similar difficulty of trying to get your hand in between the ball and the flower pot. You could think about lifting the ball from below by putting your fingers into those holes at the bottom, and that's a bit like a vaginal push-up. Alternatives are pull methods like reverse breech extraction or Patwardhan manoeuvre, and there are also some novel devices like time and tube and sea snorkel that are currently being investigated. So there's no current consensus for the safest and or most effective strategies for managing an impacted fetal head, and there are no standardised management guidelines. And this has resulted in a really widespread variation in practice across the UK and globally. There's some evidence to say that reverse breech extraction is associated with reduced maternal complications compared with a vaginal push-up. But it's not just the superiority of one technique over another that's important, as an impacted fetal head may require more than one technique. In fact, in our retrospective cohort study in Bristol, 1 in 5 cases of an impacted fetal head required more than one technique to achieve birth. So we conducted a study called the Disimpaction Study at 3 maternity units in the southwest. Obstetricians and midwives were observed managing an impacted fetal head in simulation. And this revealed a number of automated practices and skills that expert obstetricians use to deliver an impacted fetal head. And some early lessons have been identified, which I'll go on to explain in the next few slides. Importantly, you need to anticipate an impacted fetal head and prepare for it, particularly if risk factors for an impacted fetal head are present. The lead obstetrician should alert the team in the safety briefing, inform the consultant on call, and allocate a trained senior midwife or obstetrician to be prepared with sterile gloves on if a vaginal push-up is required. It can also be prudent to ask the anaesthetist to have GTN readily available if needed. Communication is key for management of an impacted fetal head. The obstetrician should calmly declare the emergency as an impacted fetal head if it is encountered. Everybody in theatre has a role to play, and all team members should be informed, including the operating assistant, midwives, maternity care assistant, anaesthetist and neonatal team. The obstetrician should request senior obstetric help if required and give precise, specific instructions on how to perform any manoeuvres. So in terms of our initial techniques and strategies, if an impacted fetal head is encountered, the obstetrician should first pause, and this would allow the uterus to relax and also prevents the obstetrician from rushing, giving a bit of space and time to consider next steps. In terms of hand manoeuvres, when the obstetrician first introduces their hand into the pelvis, it can be difficult to find space anteriorly between the maternal pubic symphysis and the fetal head. Coronial inquiries have identified repeated attempts by operators to push their hand anteriorly between the fetal head and maternal pubic symphysis as a common feature. So how can they go about it? Well, consider the shape of the maternal pelvis. The transverse diameter of the pelvis is wider than the anterior-posterior diameter. So if there's no space anteriorly, the obstetrician might wish to consider entering their hand laterally. And it's important on doing that the arm is straight and in the midline with no flexion of the wrist. The obstetrician should try to avoid applying any pressure on the uterine angles. Flexion is absolutely key to successful elevation of an impacted fetal head. The obstetrician needs to establish the fetal position and then sweep their hand over the face or occiput, flexing it into the palm of their hand. The obstetrician should also think about the direction in which they're attempting to elevate the fetal head. The direction should be towards the woman's head rather than the ceiling. The obstetrician needs to keep their arms straight, in the midline and parallel to the woman's body. In particularly difficult cases, it might help for the obstetrician to turn towards the woman's head if they're using their dominant hand to assist with ergonomics. If the obstetrician swaps to their non-dominant hand, they would of course need to turn towards the woman's feet. The next video is an example of how hand manoeuvres can be used to disimpact the fetal head. If you were unable to introduce your hand anteriorly between the fetal head and pubic symphysis, attempt to introduce your hand laterally to get below the fetal head. Keep your wrist straight and arm in the midline, avoiding any pressure on the uterine angles and lower segment. Once below the fetal head, flex it and apply traction towards the woman's head to elevate it to the incision. The next video shows how to flex and elevate an occipito-posterior baby. For OP positions, introduce your hand laterally, sweep your hand over the occiput and flex the baby's head into the palm of your hand. Maintain flexion of the head whilst elevating it. The next video, an occipito-transverse baby. For OT positions, introduce your hand laterally and cup the occiput to flex the head. Sweep your hand to the midline to elevate the head whilst maintaining flexion. And finally, an occipito-anterior baby. For OA positions, introduce your hand laterally and get right underneath the baby's head to achieve flexion. Many obstetricians favour using tocolysis, such as sublingual nitroglycerin, to facilitate disimpaction. This relaxes the uterus and minimises uterine resistance for disimpaction. However, a 2016 Cochrane review showed that there was currently insufficient evidence to support any benefit or harm. In terms of advanced manoeuvres, there's a fair amount of research comparing push and pull methods. A systematic review from 2015, together with the Cochrane review, showed that pull methods may improve maternal outcomes, reducing the risk of uterine incision extensions. And that includes pull methods such as Patwardhan manoeuvre. However, no significant differences have been found in relation to neonatal outcomes. In UK practice, vaginal push-up appears to be the most commonly used technique used first. And it's crucial that if a vaginal push-up is employed, that it's done by an obstetrician or senior midwife who has received training in how to do so, that they're familiar with the steps required, and they're confident to perform a vaginal push-up. Repositioning is also a crucial element of an effective vaginal push-up. To achieve adequate access, the woman's legs should be flexed and abducted in semilithotomy, with assistance supporting both legs. Repositioning may also, in and of itself, help to release the impacted fetal head. Communication, again, is absolutely important during a vaginal push-up, as it's really a dual process between the operating obstetrician and the clinician performing the push-up. The obstetrician should provide clear instructions, confirm the fetal position, and explain the direction of flexion required. And both clinicians should communicate their actions, feedback on effectiveness, and clearly say if at any point they wish to stop. So to perform a vaginal push-up safely and effectively, it's important the clinician uses their whole hand to do the push-up. And the obstetrician or midwife can use a Pringle hand technique, much like that used with shoulder dystocia, to enter the vagina at 6 o'clock, advancing their fingers towards the sacral hollow. You then need to spread the flattened palmar surface of all fingers to cup or cradle the fetal head. And it's really important that the clinician avoids using fewer than 4 fingers or their fingertips, as this can result in excessive point pressure on the fetal skull. As with the hand manoeuvres employed abdominally, flexion is absolutely key to a vaginal push-up. The clinician may need to modify their hand and finger placement according to fetal position. Vaginal push-up should be achieved by applying gentle pressure steadily, continuously and evenly to flex and elevate the fetal head towards the incision, whilst avoiding any jabbing or prodding motions and application of excessive pressure. As the fetal head is lifted, the operating obstetrician's fingers will be met. But it's important that if there is no progress or either clinician feels it is unsafe to continue, that the clinician stops. Alternative to a vaginal push-up is a reverse breech extraction. In order to do this, the obstetrician should introduce their hand into the upper segment to grasp one or both feet. If it's difficult to identify a foot, then follow the baby's back and buttocks and leg to reach a foot. The feet can often be slippery, so use a sterile swab to help with grip. In order to deliver the legs and abdomen, apply steady, continuous traction to one or both feet towards the woman's feet. To deliver the arms, love sets manoeuvre can be performed, gently rotating the baby's body in the midline to deliver each arm in turn. It's crucial that any application of pressure to the baby's abdomen is avoided during this manoeuvre. To deliver the head, gentle traction should be applied towards the woman's head. If the head doesn't easily deliver, then Morisot-Smellie-Veit manoeuvre can be performed to flex the baby's head whilst resting the rest of the baby on the operator's other arm. Any manoeuvres which cause hyperextension of the fetal neck should be avoided. This video now shows an example of how to perform a reverse breech extraction in simulation. To deliver the baby by reverse breech extraction, introduce your hand into the upper segment to grasp one or both feet. The feet can be slippery, so use a sterile swab to help with grip. Once the feet are secure, apply steady traction towards the woman's feet to deliver the legs and buttocks. Perform love sets manoeuvre to deliver the arms, rotating the baby in the midline to deliver each arm in turn. Avoid any application of pressure to the baby's abdomen. Once the arms are delivered, apply gentle traction towards the woman's head. If the head does not easily deliver, rest the baby's body on your non-dominant arm or ask an assistant to help whilst performing Morisot-Smellie-Veit manoeuvre to flex the baby's head and deliver it. In order to perform a reverse breech extraction, sometimes an extension of hysterotomy is required in the form of an inverted T or J incision. It's important that the obstetrician ensures that there's a clear operative view and that the baby is protected using their non-dominant hand during the incision. So, alternative management options. The Patwardhan manoeuvre is a technique which is widely performed in other parts of the world, but rarely used in the UK. It's essentially a modification of reverse breech extraction, whereby the arms are delivered first, and it can be particularly helpful in occipito-anterior positions if the feet are difficult to reach. There is evidence that it may be associated with reduced maternal complications, such as uterine extensions, compared with a vaginal push-up, but a gentle, skillful approach is required to perform it safely and effectively. To perform the Patwardhan manoeuvre, the operating obstetrician delivers both arms and then hooks their fingers under the axillae, applying gentle traction whilst avoiding any pressure to the baby's abdomen. Flexion of the baby's abdomen takes place due to fundal pressure applied by the operating assistant. Once the baby's buttocks are delivered, the rest of the procedure is done as with a reverse breech extraction. It's really important, though, that the Patwardhan manoeuvre is only performed by obstetricians who are trained to do so, as it really is a skilled approach. So, novel disimpaction devices. These include the Tiedemann tube, which is a single-use silicone tube with a rounded cup, which is inserted vaginally to elevate the head. It's been tested in simulation in a series of 10 clinical cases, but there's currently insufficient evidence for its use. There's also the sea snorkel, which is a disposable tube with ventilation ports intended to release the vacuum between the fetal head and vaginal wall, but again, there's minimal data for its use at present. And there are a number of techniques which just shouldn't be used, and they include a single forceps blade, Von-Teuse, and bladder filling. None of these techniques are supported by evidence, and use of a vacuum at caesarean section is associated with risk of intracranial and subgaleal hemorrhage. There is other research taking place into management of an impacted fetal head, and that includes the Midas study, which is ongoing in Nottingham. It's looking at the feasibility of a randomised control trial on management of an impacted fetal head and includes a UCOS study of second-stage caesarean section, a survey of parents, midwives and obstetricians, and a Delphi panel for study design. Very recently, funding has also been secured for a programme rolling out training for management of an impacted fetal head at caesarean section. We've recently developed some new algorithms for an impacted fetal head, which include a master algorithm, which you'll find in your pack, and 3 separate algorithms with details of how to perform a vaginal push-up, reverse breech extraction, and also details of those initial hand manoeuvres. So to summarise, impacted fetal head at caesarean section is relatively common, and it's associated with complications for both mother and baby. There's an increased risk in caesarean sections performed in the second stage, but it's as common in caesarean sections performed prior to full cervical dilatation. The whole team needs to anticipate and be prepared if there are signs of obstructed labour or low fetal station. This is a multi-professional emergency, and it's not just simply about training for the obstetrician. The whole team should rehearse in simulation to practice the release manoeuvres and also ensure clear communication. But more research is needed, sharing cases and experience, and soon an RCOG scientific impact paper will be published with further guidance. But to summarise, if an impacted fetal head does occur, the team need to declare the emergency and request senior support. Remember to pause. Introduce your hand laterally if there's no space anteriorly, and remember that flexion is key to all manoeuvres. Adequate access should be ensured for advanced manoeuvres. A whole hand needs to be used to perform a vaginal push-up, and be prepared to change your approach if no progress is achieved. Also remember to clearly document if an impacted fetal head is encountered, including which techniques are employed, as this will help us in terms of audit and ongoing learning. Additional sources of information are included in your supplementary reading booklet, and watch this space for new guidelines and publications coming out regarding impacted fetal head at caesarean section. Thank you.